Hello.
Hello. Hello.
Hello, Prof.
Hello, Prof. Yeah, I'm here now. And I can easily share my screen. Can you see that? Hello?
Yes, hello, mic check.
Yes,
Hello, this is just a mic check.
This is just a mic check.
Right, so Prof, could you,
Yes.
could you please go into PowerPoint mode and share from PowerPoint?
Please go into PowerPoint mode and share from PowerPoint. Yes.
Okay, full screen, please.
Okay, full screen, please. Let me go back again. Just a minute. Just a minute. Excuse me.
You may want to stop sharing for now so that you don't show any private information.
Hello? You don't show any. Okay, I'll stop it. I'll stop it. I'll stop. And then I'm going to the meeting.
Right, so since it's 5:30 now, I would like to call the meeting to order.
Since it's 5:30 now,
Guys, Dr. Muteshi is still not in.
I think I'm in now. I can see Charles up there.
There you are. Okay, now we're good.
Perfect, perfect.
Adeyemi, please start.
Yes, good evening, everyone. You're very welcome to today's webinar with Excel Teams. I'd like everyone to please confirm you can hear me loud and clear just by using the wave function I'm gonna just launch the polling now, just to be sure that everybody's here and can hear me loud and clear. If you can, please indicate in the poll that you'll see right now. Perfect. Looks good. I can only 43% have voted as at now, so I'm just going to wait for us to get like 80% to be sure everybody's ready. Thank you. 50%. Okay. For those who say it is poor, could you please raise your hands and I'll get your notes about that. Thanks. All right. Could everyone please lower your hands now? I can see you. I only want those who say it's poor, so we get a sense of what's going on. Okay. Okay, great. Okay, I think we're all right. I think we're good. We have 61% of people present. If you still think it is poor, the tech person will reach out to you to see if there's something we can do from our end. Thank you. Right, so you're all welcome to today's event, sponsored by Exceltis Africa Limited. And it promises to be a very interesting one. We're looking at the role of nutritional supplements in reproductive health. Today, I'll be your moderator. My name is Adeyemi Ogini. I'm the Managing Director and Chief Executive Officer of Intelligent Healthcare Solutions, the parent company of ThummimNG.com. I will be your moderator, and just to tell you a little bit about me, I have an MBBS from the University of Ibadan in Nigeria, and an MBA from Duke University in the USA. We started Thummim. As a platform for improving medical education in Africa, and we're very proud to be working with Exceltis to bring you today's webinar. Today's webinar, as I mentioned earlier, is focused on the role of nutritional health, or nutritional supplements in reproductive health, and we hope that you will find this interesting and useful in your practice. First, I would like to give you a sense of the ground rules, and it's basically just simple. Every mic is muted so that we can have a smooth experience. If you want to catch our attention, please raise your hands and someone will reach out to you and try to understand if there's anything we can do better. Also, if you have any questions as the sessions are ongoing, we would appreciate you to use the Q&A function. You can find that at the base of your screen right now. When you mouse over the base of your screen, there's a Q&A function. You can click on that and type in your questions, and the panelists or anyone who is responsible will be able to address your questions as quickly as possible. Before I go on, I would like to introduce our panelists. They are very notable people in the area of reproductive health. The first person I'll introduce to you is Dr. Charles Muteshi. He is a reproductive medicine and fertility specialist and an assistant professor in the Department of Obstetrics and Gynecology in Aga Khan University in Nairobi. Welcome, sir, Dr. Muteshi.
Thank you very much.
And our other panelist as well is a very notable person in the area of reproductive health, is Professor Oladapo Ashiru. Professor Ashiru is an IVF pioneer. He discovered and reported the follicle stimulating hormone positive feedback mechanism in 1979. And this knowledge is used clinically in assisted conception technologies, in which is used in the use of exogenous FSH injection in ovulation stimulation. Professor Ashiru is a professor of reproductive endocrinology at the University of Lagos here in Nigeria. And he's also the president of African Fertility Society and the chief medical director of the Mart Group of Health Services, among other leadership roles. He has also received several accolades, including being honored as an officer of the Order of the Federal Republic of Nigeria in 2005. Please welcome Professor Oladapo Ashiru.
Thank you very much. I will now proceed to...
Yes, just a second, Prof. Before we go ahead, I would like to recognize some other attendees here present, part of the sponsoring organizations. First, I would like to introduce Professor Oluwatrotimi Akinola. He is the president of the Society of Gynecologists and Obstetrics of Nigeria, SOGON. You're welcome, sir. And next to him, I would like to recognize the presence of Dr. Chris Haimaku, who is the Secretary General of SOGON. You're welcome as well. And in addition, I would like to recognize Dr. Ibrahim Wada, the President of the Association of Reproductive and Fertility Health. You're very welcome, sir. And also Dr. Benjamin Odongo Eli. I hope I got that right, sir. He's the chairman of the Kenya Obstetrical and Gynecological Society. Dr. Benjamin Odongo. You're very welcome, sir. And last but not least, I would like to recognize the presence of Professor Koigi Kamau. He is the chair of Fertility and Andrology Society of Kenya. You're very welcome as well, sir. Before we go ahead, I would like to share the agenda for today with you. Just so we're privy to how these proceedings would like to go. And just give me a second, I'll share my screen with you in a moment. Right, so this is the agenda for today, and I've just gone through the first 3 items, or 4 items. And next, we would go to a word from our sponsors, Mr. Ayo Olusoya, the country sales manager for Nigeria of Exceltis Africa, will just spend 2 minutes to tell us a bit about Exceltis. Over to you, Ayo.
All right, good evening, distinguished professionals. My name is Ayo Olusoya and I work with Exceltis Healthcare. I'm the country sales manager for Exceltis Africa in Nigeria. And so briefly, I will just take us through an introduction into the company of Exceltis, just for 2 minutes. Exceltis is a global organization that operates through a network of over 40 different subsidiaries, employing over 4,000 professionals across about 40 different countries. We provide a wide range of quality treatment options. We major specifically in women's healthcare. We have products ranging from fertility supplements to IVF solutions, contraceptives, and a host of others. These are a couple of product profile already present in Nigeria. We started operation in Nigeria in April 2018. And in Kenya, we started operation July 2019. We have products ranging from the myoinositol-based fertility supplements, Fertilady, Fertimen. We have the IVF products, the highly purified human menopausal gonadotropin and the highly purified human follicle stimulating hormone, which will be launching very soon. And of course, the vaginal health products and contraceptive formulation. All these are currently registered in Nigeria. And yeah, so for Kenya, because I said we started operation in Kenya in July 2019, these are the products that are currently registered in Kenya, but we expect more products to be registered in the coming months. And then, like I said, we major specifically in women's healthcare. So you can expect a wide range of portfolio in the area of women's healthcare. Our mission is to make a difference in healthcare by providing access to new, effective, and first-in-class therapeutic solutions, develop new products by conducting research to improve healthcare in the future. And we do this to improve the lives of millions of people around the world. I want to say a very big thank you to everyone who has logged into this webinar. We do not take it for granted, and I hope that at the end of this session, it would be worth your time and you would have a very rewarding and productive session. Thank you. So I'll hand over the mic back to the moderator.
All right, thank you very much, Ayo. We're very happy to be associated with you. And without further ado, I would like us to go into the first session. This first session, Professor Ashiru will be speaking to us about the role of nutritional supplements in preparation for IVF. One of the things, before he goes on to his presentation, Professor Ashiru will tell us if he has any conflicts of interest, any relationship with Exceltis or otherwise. Professor Ashiru. Prof, are you there? Sorry, just give us a second. We're trying to figure out the challenges there. Thank you.
Yes, sorry, I just reached out to him. He's trying to connect. He had a technical difficulty, but it's being resolved. Yes.
All right, no problem. It's one of the things we have to live with, coordinating life in the digital world.
Exactly.
Okay, so while we're trying to set up Professor Ashiru, I'd like to move on to Dr. Muteshi. Dr. Muteshi's session is, and then once he's done, we'll go back to Professor Ashiru. Dr. Muteshi will be talking. Okay, Dr. Muteshi will be talking to us about evidence-based review of the effect of antioxidant supplements on semen parameters. Dr. Muteshi, as I said earlier on, is a specialist in reproductive health. And Dr. Muteshi, I'll give you like maybe a few seconds to set up, and would enable you from here as well.
Okay.
Okay, so we can see you. And please let us know if you're able to share your screen, sir.
Are you able to see my screen, please?
Yeah, perfect.
Okay. So I set off because I think we've done the introductions. I'll be discussing about antioxidant supplements and male fertility. I did modify that a little bit just to encompass the whole spectrum, and this will be an evidence-based review. This is where I work. I'm based at Aga Khan University Hospital in Nairobi. This is a tertiary health institution, and I work here as a fertility specialist. I haven't got any conflict of interest to declare. So the scope is targeted on looking at male fertility. I will then discuss the temporal decline in sperm count and what that has got to do in terms of implication on general health. We'll go into the diagnostic evaluation of the infertile male, look at the advice we would give to the couple trying to conceive, and then narrow in onto the antioxidant supplementation for males of fertility. So just as a general overview, back to the basics, we do understand that spermatogenesis is a very delicate process that happens at the level of the seminiferous tubule. And obviously, the spermatid has to go through the maturation steps, which are very delicately orchestrated by the hormonal milieu. And we're talking about the hypothalamic pituitary testicular function. Now, the testis is a very specialized organ because apart from producing the hormone, testosterone, also produces the gametes for reproduction. And as we shall see in the subsequent slides, this process is reliant or heavily influenced by environmental and lifestyle factors. And obviously there'll be some genetic factors also. So there's been concern over the last 50 years or so that perhaps there's been a temporal decline in sperm count. This was first reported in the late 1980s. And a more recent review looked at the sperm parameters between 1970 and 2010. As you can see on these two slides, panel A is looking at sperm concentration, which has actually declined 52.4% between 1970 to 2010. And panel B shows the decline in the total sperm count. And this is both in unselected and fertile population. However, this is not a global representation because it's mainly based on Western Europe and American data as well as Australia. But what is interesting is that there is a 0.8% decline in sperm count per year which has been projected from these. And why are we really bothered about sperm count? It is because this is associated with fertility. And if you look at this graph, again, it's based on Japan, US, and European Union data. And the dotted line, about 2.1, just shows us the total fertility. So early in the 60s and 70s, the graph was above the fertility rates, but with time it appears that the human race may struggle to replace itself because fertility rates are declining. There might be different reasons for this, perhaps a use of contraceptives and other reasons, but this worries because it's also linked to reproductive function. The other important reason why we worried about sperm count is actually related to mortality and morbidity. And an elegant and interesting study done in the US published in Human Reproduction actually has shown that as the sperm count declines, there is corresponding increase in male mortality and morbidity. More importantly, is the fact that we can see environmental and epigenetic influence on human reproduction, and particularly the concept of testicular dysgenesis syndrome. You can see that there are environmental exposure, genetic defects and polymorphisms, and lifestyle factors. Now, all these have resulted in an increase in conditions such as cryptorchidism. We know there is an increase in conditions like hypospadias, the short genital distance, and even perhaps a decrease in hormones such as testosterone. And even more worryingly, if you look at cancers like germ cell tumors, are shown to be on the increase. And that also correlates with sperm counts, as we've seen in previous slides. So when we come to look at male fertility, it's an area that is actually quite interestingly difficult to study, but presumably we think we get figures very easily. But because we see patients who come to clinic, we assume that we can predict the prevalence of subfertility in the community. It's not entirely true, but some of the studies have shown prevalence that hover between 9 and perhaps 20% by asking cross-sectional studies in the community about male partners of couples who have experienced fertility problems. Of course, they've got limitations because they're not testing anything, but asking question whether a man has experienced fertility. And one of the limitations of this, of course, will be that it will be a couple who experience fertility problems, and asking one partner alone may not be comprehensive enough. So I will be focusing on how to evaluate a subfertile man in the couple. And the reason for this is that we would like to identify conditions that are corrected or correctable so that we could improve general health and also improve fertility. It is also important to identify conditions that are irreversible, which means the chance of natural conception is decreased, and that can be overcome by performing ART. But there are also conditions that are irreversible, and it will also mean that the male may not get a biological child and therefore amenable to use of donor sperm. But the two last bullets are interesting because they focus on serious medical conditions that if we didn't look deeper would have significant consequences. And we're talking, for example, about testicular cancer. So a man who presents to the fertility clinic with a low sperm count, if you don't think about that, then you may be treating their fertility problems and overlooking a serious condition. Also, there will be situations in which there is risk of passing genetic defects or diseases to the next generation. And we now have technology that can help overcome these difficulties. So I've just projected a flow chart which you could use in your clinics, just basically going through the motions of evaluating a man who presents with potential fertility issues. Now, you don't have to do everything, but it's very important that a history and physical examination are as comprehensive enough so that we can pick out any abnormality. And it's always nice that a semen analysis is performed. How many of those are necessary is debatable, but a single semen analysis is good enough to pick out areas that can guide in further evaluation. And if there is any abnormality that is picked up, then a referral to a male fertility specialist or a urology would be essential. So I wouldn't want to go through the details, but you can see from here that a history is important that will elicit whether there is any underlying medical conditions, and particularly around reproductive maturation, if there is any childhood illnesses that may point to a particular area. Lifestyle factors, previous surgeries, and obviously use of recreational supplements. This is an area that is very important because of peer pressure and sometimes image projection, and men may end up using anabolic steroids or other supplements that can actually harm their fertility prospects and could also potentially have consequences on general physical health. The examination ought to be general and targeted, and it's important that one considers obesity as a key area of evaluation, and assessment of virilization, because this will be important physical findings that will guide towards possible etiologies or underlying comorbidity. Assessing and examination of the testes is extremely important because even before you get to know the results of semen analysis, you may be able to pick out areas that are significant. For example, testicular size is a direct function of spermatogenesis, and it will also indicate whether there might be underlying testicular disease. We've talked about cancer, which can also be picked out by physical examination. And more importantly, if you look at and examine the ductal structures, and when you correlate that to sperm findings, you may be able to tell, particularly if you're dealing with azoospermia, for example, that's very, very easy to pick out if there's obstruction from lack of seminiferous tubules, for example, or the spermatic cord and the vas. And then a laboratory evaluation, it's good to start off with a simple semen analysis. And depending on what the findings you've got, then you may do more advanced tests, including hormone profile, and we'll discuss this further. So this is the 2010 version of the WHO semen analysis, which gives you the least 5th percentile of the values that will predict fertility over 12 months. A sperm concentration of 15 million per male is important, and a forward progressive motility of 32%. The other factors on the sperm analysis, for example, pH, if it's azoospermic sample with low volume and low pH, that will tell you that you're dealing with an obstructive azoospermia as opposed to non-obstructive azoospermia. Endocrine evaluation is important, especially if the sperm concentration is less than 10 million per mil, if there is impaired sexual function, or if there is clinical findings of endocrinopathy. And what do you need to do? It's very simple, just to run an FSH, an LH, testosterone and prolactin levels. And if there is normal spermatogenesis, then all these hormones will appear normal. But what is important is to notice that if there is abnormal spermatogenesis, you may not necessarily have abnormal hormone profile, but more commonly, the FSH will be raised or in the higher normal levels. And obviously, if there is testicular failure, then you will have raised FSH and LH and low testosterone levels. Just to mention that if you have azoospermia, but the hormone profile is normal, then you're more likely dealing with an obstructive picture, especially if you did a testicular examination, which shows that testicular volume is as expected. Other tests, scrotal ultrasound, this will depend on what you find on the history and the physical examination. And it's important, particularly if you want to rule out serious conditions such as cancer, and a history of cryptorchidism would be a lead in that sense. Genetic testing would be important, especially if the sperm count is low. And we do know that the commonest would usually be sex chromosome abnormalities, particularly Klinefelter syndrome. And this may be as high as 15% in men with azoospermia. In men with low sperm count, the prevalence of genetic abnormalities will be as high as 5%. Whereas finding that in men with normal sperm would be less than 1%. So that will guide you. Again, the emphasis of this is that you wouldn't want to just blindly be treating low sperm count without thinking that there could be an underlying serious comorbidity. So I'm just gonna spend a few more minutes to discuss about oxidative stress. And the reason for this is that up to 30 to 80% of men with fertility problem may have underlying oxidative stress. And this is mainly from reactive oxygen species. And what this does is that these molecules will destroy the sperm membrane, and obviously that has a direct effect on fertilization. But apart from that, it will also destroy the sperm DNA integrity. And we see a lot of that, particularly in the IVF setting, where you may think that you would like to overcome fertilization problem by doing ICSI and end up with situations such as maturation arrest, failed implantation, or miscarriage. Now, seminal plasma is very rich in antioxidants, and these serve to support, protect, and nourish sperm. And these are actually quite simple molecules because they're just nutritional supplements and vitamins. For example, vitamin E, C, folate, zinc, selenium, and the rest as projected here. So this is a busy slide, but what it's entailed to show is the balance between reactive oxygen species and the antioxidants and the interplay from environmental factors that may tilt the balance towards a more harmful environment for sperm. It might be idiopathic. However, we do know that there are certain lifestyle factors that may promote this harmful environment, particularly smoking, obesity, alcohol, advance in paternal age, and conditions such as occupational exposure. We well know about pollution, heavy metals, and pesticides. But I think looking at our environment, we do have a lot of infectious conditions, and sometimes something like chlamydia tends to be asymptomatic, or it may be treated suboptimally, and you end up with chronic inflammation, which perhaps will result into dysfunctional sperm performance. There is very recent paper which showed failure of IUI treatment that has been linked to active HPV infection. So we do know that we possibly have HPV in the environment where we work in. We haven't studied it specifically because we tend to focus our attention more on HPV and cervical cancer and not much on male fertility. So it might be an area of interest to look at this in future. But overall, what we tend to see then is that if there is an imbalance in the antioxidants against the reactive oxygen species, then that leads to sperm DNA damage and membrane damage as well. And that has a direct effect on fertility prospects. What are some of the factors that may make you think that there might be a higher chance of oxidative stress? If there is poor sperm motility, that's one. If you look at a sample that is teratospermic, which means the morphology is very, very abnormal. If there is a high number of round cells, so this could indicate perhaps an increased leukocyte count, but you have to be very careful when you're looking at your laboratory quality control, because immature sperm may be classed as leukocytes. And if you are doing more advanced treatment, especially in the IVF setting, and you're faced with poor fertilization failure, if you're doing conventional IVF and you notice that overnight incubation of sperm with oocytes results into poor motility, or if there is poor blastocyst development, then again, this could be pointing towards oxidative stress. And generally what we tend to see then is increased sperm DNA damage. What are their treatment options? It is as simple as lifestyle modification, advice on stoppage of smoking, improving diet and weight loss, minimize environmental exposure, and treatment of identified conditions such as infection. Surgery to ligate varicocele may also improve the oxidative environment, and especially where there has been poor reproductive function. Now, it's very important to mention here that you don't have to treat all varicoceles if there is additional female factor to the subfertility, because this is not going to overcome the problem and result into a live birth. So if there is concomitant female factors, then it's best to refer to a fertility specialist who may recommend advanced fertility treatment. We do know that there is some evidence that use of antioxidants and vitamins could improve the environment in the seminal plasma. And where you have used antioxidants and reproductive outcomes remain poor, particularly when you're looking at advanced treatments, then surgical sperm extraction may overcome this because it's assumed sperm that is at the testicular level has not been exposed to the reactive oxygen species when it's in storage. And obviously, if there are any laboratory parameters that could worsen the situation, then you need to look at your protocols. I'm just going to spend a few minutes to talk about the evidence around antioxidants. And the reason why I had to go through the basics and what you need to know regarding sperm parameters is the fact that you don't want to jump onto giving treatment when you could potentially overlook something that is significant and could cause morbidity. And the important thing to always remember when you're treating a patient with abnormal sperm parameters, when you give antioxidants, is that the clinical outcome is live birth. You're not giving antioxidants to repeat the same sample and tell them, you know, your sperm count has increased from 1 million to 3 million. It is how you're going to improve live birth in the end. And I've looked at some of the evidence and picked out a few slides from a very recent Cochrane review that has shown weighted benefits in patients who were given antioxidants when they looked at live birth. The caveat is that this is a systematic review of about 48 studies, but only 4 of them have reported on live birth. So that could limit that interpretation. But it's quite reassuring that the odds ratios are actually in favor of increased live births. It's also very important to notice that clinical pregnancy improve or increase when antioxidants are given. Now, this is reassuring, especially in the context of miscarriage, because we do know now there is evidence that emerging miscarriage is not entirely just an oocyte thing, but there's a strong influence of sperm. And the effect of sperm is not necessarily genetic, but is related to sperm DNA integrity, which is then a function of oxidative stress. So some studies have actually shown that when you've given antioxidants in a couple who've suffered miscarriage before, you're possibly going to improve the chance. And now we also had good evidence from what we call the Hub Select study in IVF, whereas it did not increase the overall live birth rates in sperm that was prepped with hyaluronic acid, we saw a significant decrease in miscarriage rates. So it does tell you that there is a role of oxidative stress in sperm in the etiology of miscarriage. It's very reassuring to note that there isn't any adverse effects from using this form of treatment. And if you look at maybe sperm DNA fragmentation, which might be an important parameter, use of antioxidants can actually potentially reverse this. But you should always remember that you are talking in the context, especially where you would like to enhance natural conception, where there is either unexplained subfertility or mild male factors of fertility with no underlying female problem. If there is severe male factors of fertility, then whereas there might be marginal improvements in sperm parameters, it may be more harmful, wasting time and waiting, because the female factor, which is age, also predicts the chance of advanced reproductive treatment outcomes. So spending time delaying definitive treatment may be more harmful in the end. So just to summarize, fertility is probably on the increase. There might be multiple factors, but we do know perhaps that environmental and testicular dysgenesis syndrome may play a role. We tend to think that advancing maternal age may be the only reason why fertility is decreasing, but that's actually not true. There is actually a corresponding decrease in male fertility with also other conditions. For example, cryptorchidism, we've talked about increasing testicular cancer. So a comprehensive assessment of the male factor is certainly very important. So you don't miss out anything. You refer appropriately and quickly. And where there is advice that is to be given, then that is offered timeously. And a holistic approach would be certainly advisable. So a man who is obese would be given antioxidants, but at the same time should be advised to improve their lifestyle. I'll stop there. And thank you for your attention. I think questions may come at the end.
Yes, thank you very much, Dr. Muteshi, for that presentation. So in the meantime, I would ask that every attendee, if you have questions, please use the Q&A function that you find at the base of your screen right now. Also, we would like for every attendee to, as much as possible, identify yourself appropriately using like a name, because for some people, we'll notice that what you have is like a generic name from your phone or something. That helps us a lot when we're issuing the eventual certificate of participation. So please, let's attend to that. Without further ado, I would like to invite Mrs. Melanie Ribeiro. She's going to give us a bit more insights into Exceltis and the brand. Welcome, Melanie. Once Melanie is done, then Professor Ashiru is going to talk to us about the role of nutritional supplements in IVF treatment. Thank you. Melanie?
Thank you very much, Adeyemi, for the kind introduction. My name is Melanie Ribeiro, and I am honored today to be able to present to you the Exceltis fertility supplements. So I will start, first of all, with the Fertilady, the X-Line Fertilady, which contains myo-inositol, 2,000 milligrams, and a number of clinical trials have actually been done. One of them by Zeng et al., which was a combination of a meta-analysis as well as systematic reviews published in 2017 in Medicine, which actually looked at 7 randomized clinical trials with more than 900 women who were infertile, and they gave them 4,000 milligrams per day of myo-inositol. And the rate of pregnancy, the clinical pregnancy, was significantly increased. The abortion rate was significantly reduced, and the quality as well of the oocytes and embryos were greatly increased by the 4,000 milligrams of myo-inositol. The second ingredient here is L5-methyl tetrahydrofolate. This is the bioactive form of folic acid, and I'm sure it'll be addressed later on, but we know that for a fact there are a number of patients who are unable to metabolize folic acid, the synthetic folic acid, to its active formulation, and which can then be absorbed and used at a cellular level. This formulation is actually already bioactive and can be used straight away at the cellular level. We also have vitamin B12 or cyanocobalamin, which is a key ingredient for implantation as well as conception. Now, where should the product be used? As I said, there's a number of studies that have been done when you talk about IVF in the infertile woman, whereby myo-inositol in combination with folic acid has proven to be very, very effective in increasing the clinical fertility rate and the clinical pregnancy rate. In women with polycystic ovary syndrome as well, we have, there are a number of studies that have been done. One of the most interesting ones is by Victoria Unfer, which was a review and meta-analysis published in both 2012 as well as 2017 with a large number of women with polycystic ovarian syndrome with anovulatory infertility. Now, what they found in these women is that not only did they have much better pregnancy rates, they also found that the hormonal balance and cycle regularity was restored. And they also found that at the ovarian level, this is where you actually got with myo-inositol and not with D-chiro-inositol, very high quality oocytes and embryos. So it works very well at the ovarian level. Also effective as an adjunct in improving IVF outcomes. Now the second product Dr. Muteshi has made very easy for me because he's already discussed with you the issues involved around the reactive oxygen species. So we know for a fact that the spermatozoa and critical phases of spermatogenesis are really very, when it comes to being, when it comes to the reactive oxygen species, they're very, very vulnerable compared to all the other cells in the body. So having an appropriate antioxidant is very, very essential here. Myo-inositol at a high rate of 1,000 milligrams per day is very, very essential in not only being a very strong antioxidant, in improving the sperm motility, but also the effect on morphogenesis and cytogenesis, and stimulation of capacitation and acrosome formation. We all know about L-arginine, that this is a critical amino acid in the body involved in vascular function, but also the precursor of nitric oxide, which if the patient is deficient in that, you will have many issues even with erectile dysfunction. Tribulus terrestris is a plant that has been used for many years in the East, in Asia, in Europe, for management of sexual dysfunction. This is a plant that if patients are able to take it or extracts from it, like the saponicides and protodiosines, are actually able to improve the sperm concentration, the mobility of the sperms, as well as the sexual desire, sex drive, quality and duration of the penile erection as well. L-carnitine is a very important for enhancing motility. The others, vitamin C, vitamin E, zinc, vitamin B12, the livermofolic acid and selenium, as we've mentioned, these are key antioxidants. They are also very key in the spermatogenesis process, especially for zinc and selenium, and as well as several enzyme cofactors. X-line 30Men is very key in increasing the sex drive in men, increasing male erection, sperm count, sperm quality and motility, as well as improving fertility in men. The dosage is 1 sachet per day. Both 30Men and 30Lady come in a full monthly dosage pack. So the patient just needs to buy 1 pack and they'll be able to, go for the full month. Thank you very much. That's all I had for you.
Thanks a lot, Melanie. That was short and sweet. And next on, Professor Asheru is back in the room, thanks to technology again. And he will be talking to us about the role of...
Back, please.
Yes. He'll be talking to us about the role of nutritional supplements in preparation for IVF. Prof, are you able to project from your PowerPoint?
Yes.
And may I say that as we as Prof goes on with his presentation, if there are any questions, please feel free to use the Q&A function at the base of your screen. We will take all questions once this session is done. Thank you very much.
Yes, so we're talking on nutritional supplementary and supplementary therapies in IVF. These are very important factors in IVF. They are also regarded as adjuvant therapies and IVF. I don't have any disclosure that has any financial compensation. Let me give you the background with regards to IVF. Is that first of all, it was Edwards and Steptoe who pioneered IVF in 1970, and with the birth of Louis Brown in 78. Although we know that thereafter, several attempts have been made to improve this science. They've been targeted at improving the understanding of oocyte yield and embryos, embryo-endometrium interaction and communication, the culture media improvement, laboratory conditions, the use of technology like embryoscope, and the use of adjuvant therapies. The rationale for the use of adjuvant therapy mainly is to improve ovarian function, to improve sperm function, influencing uterine receptivity, increasing ovarian blood flow and or uterine vascularity, as well as implantation support. We do know that assisted reproductive technology comprises in vitro fertilization. It has to do with the management and manipulation of the female and male gametes in vitro. The basic science in this field, but for the work of Changa and Yamaginashi in 1969, it would not have been possible for Steptoe and Edwards to even manipulate the sperm in vitro to have fertilization. The next science in this field was by Andrew Charley and Guilleman, who received Nobel Prize in 1977 for their ability to isolate the hypothalamic extract, LHRH. This was used by Ashiru and Blake in 1978 to describe the FSH positive feedback, which is now used in ovarian stimulation in terms of exogenous administration, FSH. Of course, we all celebrated the World First Tube Baby by these two people and the nurse, Peter, who worked with them at Oldham Hospital. Thereafter, it became a race globally to join this team. Historically, we were happy that in Nigeria, we also became part of this team with a first attempt in 1984, which was an ectopic pregnancy, followed by subsequent attempt in 89, 86, and 89, and the birth of a baby. Thereafter, the need for IVF moved into pre-implantation genetic diagnosis, the immunology process in IVF, and the use of drugs and modern medicine. Those adjuvants that we have in reproductive technology, they consist of the early ones like growth hormone, followed by corticosteroids, minoxidil, non-steroidal anti-inflammatory drugs, DHEA, and a host of others. What I have done is to select, because there are batteries of antioxidants that are being used, and a consortium came together over a period of time to select those that are actually, through randomized control trials, being useful. What are the bases of these antioxidants? We do know that the reproductive organ is controlled right from the higher centers, and the process of ovulation and spermatogenesis, it's like an orchestra in symphony, and those components must work together. In that orchestra, the pituitary gland is the conductor, hypothalamus is the composer, and pineal gland is the rhythm. So they are all needed, and from pancreas to adrenals, thymus, and liver, they feed back to affect reproductive function. when you look at the adrenal, it's a safe flight and fight, and it guarantees the energy to survive, and it is implicated severely in polycystic ovarian syndrome. And if you look at the camel carrying the weight, it is the weight that we put on the adrenals from the pancreas, from other sources like heavy sugar intake that makes the adrenal to be overworked. Now, what are the components of this steroid metabolism? You're looking at the cholesterol chain, the cortisol, DHEA going to testosterone and going to estriol. And then progesterone being one of the products. But I will now give you what the nutritional supplements do as cofactors to this production. You can see vitamin B3 in the axis from cholesterol synthesis. Then you see vitamin A, E, C, and zinc going to DHA formation, and as well as in the progesterone conversion to testosterone to estradiol. Vitamin E is very important. And then you have B5, folic acid, and vitamin C. So growth hormone, or a biological peptide, has been used by some people. It's produced by the somatotropin in the pituitary gland. But all the studies were done did not produce any consensus on the route of administration in IVF protocol. But the critical point is that studies suggest that the growth hormone is an important adjuvant in improving implantation rates in poor responders. And these are some of the studies that show this in terms of comparing the studies by Duffy in Journal of Metabolic and Nutrition that from 2010 in women. And then another studies show that the mechanism of action is to modulate the effect of FSH on granulosa cells, regulating the local synthesis of insulin growth factor 1. IGF-1 displays growth hormone dependency, both in vivo and in vitro. That was shown by Bloomfield. And increased gonadotropin activity in the ovary, augmentation of aromatase activity, 17 beta estradiol and progesterone production, and LH receptor formation. These are the components that have created the need for the use of growth hormone. The next hormone that is commonly used in this environment is prednisolone. It's a corticosteroid. It is an immunomodulation. It reduces uterine lymphocytes, peripheral immune cells, natural killers, and it reduces endometrial inflammation. And it normalizes the cytokine expression profile, which are the factors that lead to natural killer cells in the body, in the uterus level. There's another type of the corticosteroid is dexamethasone, which some people use. It directly influences follicular development. Indirectly, and by increasing serum GH and IGF, is consequently the follicular fluid and IGF. So this is also being used in terms of support of follicular maturation. Dexamethasone sensitizes the ovary to gonadotropin, so it enhances ovarian response, and it enables the follicles to respond to stimulation, and it produces health of developing oocytes are well done. So it is therefore prudent to say that dexamethasone is an excellent adjunct for poor responders undergoing IVF. Those are the indications: normal patients, patients with autoimmune problems, poor responders, and patients who have undergone assisted hatching of the zonal pellucida because they had zonal hardening. There have been a lot of success rates reported with dexamethasone and with prednisolone. So these are a very low cancellation rate with dexamethasone and increased pregnancy rate, and pregnancy rate also increasing dexamethasone. we do know that the flaw is that not many quality and well-designed studies were available to allow clear conclusion about the possible benefit, but I would still say that the benefit of corticosteroid treatment is still on the positive side. Then the next one is myo-inositol, which Melanie has spoken about. We do know that myo-inositol has received a lot of studies, but what I've done is to create, highlight some of its value in terms of it increases clinical pregnancy rate. It may improve the quality of embryos. It reduces the unsuitable oocytes and the required amount of stimulation of drugs. So you'll be using less drugs if you prepare your patients with myo-inositol, and it's also helpful in improving IVF outcome in PCOS and poor responders. I have shown you that some of the studies that have indicated this effect of supplementation of myo-inositol plus melatonin on oocyte quality in women who failed to conceive in previous IVF. They had good results. This was a study in Italy. Then myo-inositol supplementation reduces the amount of gonadotropins and the length of ovarian stimulation in IVF in patients or in women undergoing IVF. That was a systematic review with meta-analysis randomized control trial. And then myo-inositol improves clinical pregnancy rate in infertile women undergoing ovulation. This is myo-inositol, and that is about chemistry in terms of its improving the outcome for PCO and poor responders. This was the study that went through the pathophysiology and the approach to this drug. These are some other studies in terms of its work on poor responders, prospective studies, observational trial, and also in terms of its improving, this is very important, it may improve the oocyte quality in intracytoplasmic sperm injection cycles. In other words, when you do ICSI, the quality of the oocyte may be improved after when you treat them by ICSI. That was a prospective trial that was done. And two other trials studies have put here, but I think they all conclude to say that this is very important. Myo-inositol supplementation reduces the amount of gonadotropin and the length of ovarian stimulation in women. That has been stressed by me. But the study about the expert review of clinical trial showed here that when you use myo-inositol and they compared with a dichloroinositol, that the dichloroinositol is not very helpful because it doesn't get into the ovarian tissue. So it may be of no value to your stimulation. It's better to use the myo-inositol process. The next component is omega-3 and oocyte. In a 98 women with prior complete fertilization failure, omega-3 at 1,000 milligrams were given daily for 3 days prior to the cycle. Fertilization rate was higher, about 76.5 versus 50.4, an increase in good quality embryos, and so was the implantation rate. So this was published in Fertility and Sterility by Kim. So this is a very important thing. It is equally of use in men, and it has one of the products found to improve sperm morphology. DHEA is a precursor of ovarian steroidogenesis. It augments ovulation, induction in poor responders with normal FSH level. It's mostly retrospective studies in 205 women, and the dose was DHA 25 milligrams 3 times a day for 4 months prior to IVF. It improved the number of fertilized oocytes. These are the aspect that DHA, it decreased cancellation rate, it improved pregnancy rate. That was the study by Barrett in 2007. It decreased miscarriage rates by reducing aneuploidy. That was by Norman Glacier. And then it also, by Norman Glacier again, increased in serum AMH. So we can see that there is a significant value for the use of DHA with higher live birth rate and improved embryo quality. I know that quite a number of people use that in this environment. This is the method of work: increase IGF production during stimulation and reducing follicular apoptosis, and especially beneficial in aging ovarian environment. This is NSD, low dose aspirin is very important for implantation because of the vasodilatory and anti-inflammatory action, as well as the inhibition of platelet aggregation. In fertility and sterility, low-dose aspirin treatment improves ovarian responsiveness, uterine and ovarian blood flow velocity, implantation and pregnancy rates undergoing in vitro in patients going through IVF. That was a good study that was done. The dose is usually 100 milligrams daily, and those are the outcomes. There are different types, but it's also good in reducing incidence of ovarian hyperstimulation syndrome. The next group of supplements which come in nutrition have been spoken about before. The first one is zinc. This is the most researched mineral in the management of infertility. And you know that currently, with the advent of COVID-19, zinc is being reported to be very helpful when the chloroquine is used as a supplement in the treatment. That is when it's more effective than without chloroquine, but that's some studies. It helps in producing mature egg. It helps to prevent miscarriage in low level, as low level is associated with early miscarriage. It helps in the maintenance of follicular fluid, and it allows the ovum to travel through the fallopian tube to the uterus. It stabilizes the level of hormones such as E2 and P4, as I shown in the early slide, that is helpful in those conversion process. And it helps to reduce the size of fibroid as a known cause of infertility. Magnesium is another one. It aids in egg and progesterone production. This prevents fallopian tube spasm, allowing the embryo to travel safely to the implantation site, and it increases blood flow to the uterus. Then there is the folate and folic acid. This is very important. As you know, that WHO had recognized that anybody going through conception should try and take either folate or the folic acid. They increases progesterone, sperm quality and count, improves ovulation, it improves production of genetic materials, DNA and RNA. It protects the genetic code of the embryo. As you know, that folic is one of the components of the gene. It reduces the risk of preterm and low birth weight. It keeps cortisol level under control, allowing pregnancy to thrive. It reduces the risk of miscarriage, like in preeclampsia and premature labor, fetal growth, retardation, and infant death syndrome. This is I showed this pathway to tell you that if you see folic acid being moved into homocysteine and then being converted into the 5-methyl tetrahydrofolate in order to become glutathione. Now, this is the active components, and the end result is glutathione. But if you are not able to convert folic acid into this process because of the absence of the enzyme tetrahydrofolate reductase, you are going to accumulate homocysteine. And some people have this metabolic problem. So in such people, when you give folic acid, you're not going to get the glutathione which is needed in the cell. You're going to get accumulation of the homocysteine. So you're just preloading them with folic acid without any problem. So a number of studies have been cited to show that methylene tetrahydrofolate and IVF is more important than folic acid, especially because some people they have a genetic problem that they are not able to produce the enzyme methyl tetrahydrofolate reductase that will convert the folic acid into its active form. That is why some people prefer to use the folate as opposed to the folic acid. These are some of the studies that have been shown in this field, and I will summarize them in this format. Impaired folate due to the polymorphism of the enzyme methylene tetrahydrofolate reductase will not give you enough folate in the body. Couples undergoing fertility treatment may benefit from genetic screening and supplementation with the 5-methyl tetrahydrofolate glutamine salt, that's the active folate, instead of the high dose of folic acid traditionally used. I think what Exceltis is giving is the MTFR, which is the folate. Although the benefit of folic acid is widely recognized, many people may not benefit benefit from it due to the genetic problem. So it's better to err on the safe side if you are able to get the folate. The next one is vitamin B12. It works in synergy with folic acid. It's essential for ovulation. It improves sperm count, boosts endometrial lining. It is required in the production of DNA and RNA for sperm and egg, as well as protection of genetic code. Its positive effect on implantation keeps hormonal balance, and it reduces miscarriage and aids in carrying pregnancy to term. My next talk will be on selenium. Selenium is an antioxidant protecting the body from free radicals. This is very critical because, as the Dr. Metui said from Kenya, there are a lot of heavy metals in the environment. Mercury from fish and several other heavy metals like lead in water and arsenic in rice. So in order to help our patients, selenium is very useful because it mobilizes these heavy metals from the body, especially those who may not be able to afford a comprehensive detoxification. It's essential in sperm formation, sperm count, as well as its motility, and it prevents chromosomal breakage, a non-cooperative in birth defects and miscarriages. Because heavy metals like mercury and antimony, they all create miscarriage components or abnormalities. So folic acid will protect the patient from such problems. This is a copious research, a systematic review that shows that selenium can promote healthy follicles in the ovaries, which develop and release the eggs. This antioxidant can also protect against birth defect and so on and so forth. CoQ10 is for cell production, and it improves the quality of oocytes in women, and it's very good also for sperm. Lastly is the modern male medicine. This is in recognition that there are environmental stress in the body, and it uses these bioenergetics combined with other tools and equipment to remove toxins, distress, and this is what we've been working with the FIGO Committee on Reproductive Environment and WHO in terms of the fact that there are environmental toxins in the body, and it uses, for the sake of time, all I will tell you is that all the toxins, all the heavy metals that we take, they're coming from the mouth into the liver and to the systems. And there are processes in which they can be cleaned out by cleaning this process. The priority statements is that too much food leads to malgradation, fermentation, and putrescence. And when meal comes in, and when there's this fermentation, these components, toxic metabolites, alcohol, are accumulating in the body. So also are the biogenic elements are accumulating in the body. So we use therapies like capocicator, physiotherapy, hydrotherapy, electrolyte filters, and other things to remove those toxins in the body. Capocicator is giving a high level of oxygen delivered into the cells directly through a respiratory system like this. And so he's getting 15% oxygen and 9% and then at incremental doses, so it gets low and high level oxygen, which helps to break down the aging mitochondria and improve and multiply the good ones. Mitochondria has about 30 billion cells in the body, and this is the energy power for every organ, ovary, and the egg, the oocytes, and the sperm. So when you reinforce them, they are able to give you good quality. So there is the energy production cells. So if you can help by improving the oxygen level and reducing it, it will methodically destroy all mitochondria and accelerate the replication of healthy ones physiologically, the young mitochondria in the cells. So it's been helpful to stem cell activation, synthesis of CoQ10, and support regeneration in the ovaries and the testes. We have the physiotherm, which is infrared, which is involved in terms of circulation to all the reproductive system and the organ system. It gently heals and soothes and stimulates and detoxifies the body. This is the way it works. As opposed to the sun, this is going directly into the spine and all the organs, and the body gets reactivated. Improve circulation, vasodilatation, improve blood supply, and cleansing of the heavy metals and chemicals. So, and then it helps to detoxify, anti-aging, and wound healing. In summary, various attempts have been made in pursuit of the better understanding of novel methods of improving health outcomes. The use of adjuvants have been received with mixed feelings by experts. Some therapies showed improvements in some of the subgroups of patients. Reviews, however, show that they were lacking in clear-cut evidence, probably due to some simple sample size or lack of multi-center randomized control trials, limited understanding of the immunological and biological and endometrium interaction with adjuvant use. For me, I believe that whoever is able to solve this problem of the embryo endometrial interaction is probably a room for the next Nobel Prize, because that will reduce, that will improve the pregnancy rate to close to 90%, which we hope to be available by 2025. Legislation against in vivo studies is a contributory limiting factor. Poor research tool is also a limiting factor. In conclusion, I will conclude by saying that adjuvant therapy are useful. Use what you can access. Use what works for you. With more randomized control trial, definitive rules of adjuvant therapy can be determined. I thank the Medical Art Center team, the Math Life Clinic team, Math Diagnostic, Math Doctor, and Math Medicare, and OAS Foundation for the support in all this research. And I also thank the Exceltis for asking me to come to this webinar. And I thank you all for listening.
Oh, thank you very much, Prof. That was a very enjoyable session, I believe. So next on our agenda is to deep dive into the questions. I know that Dr. Muteshi has been answering some of the questions online, but there are some of them that we would bring into the live session. And so basically just to make sure that to disseminate a lot of the answers more broadly. So I'm going to unmute Dr. Muteshi now. Prof would also, we're going to take questions for like 10 minutes, and then we're going to Prof, the questions that are directed at Prof, or if he wants to chip in on any of them. Okay. So I'll, Dr. Muteshi, you ready?
Yes, please.
You seem to have some background noise.
Some background noise, sorry.
Okay, I'll give you a minute to just sort that out.
Okay, I think that's fine now.
Oh, perfect, perfect. So
yeah, I'll just read through the questions as I run down. First question asked, I have a zoospermic man with small testes. What's your advice? So basically, it's usually to differentiate between obstructive and non-obstructive azoospermia. It's very likely a man with small testes will be having non-obstructive azoospermia. But to just get more information, apart from the physical assessment, is to do a hormone profile. And if this comes up as hypergonadotropic hypogonadism, and then it will be indicative of testicular failure. Now, what is reassuring now is that even in such situations, even when men have Klinefelter syndrome, if you did a karyotype, you still have about 50% chance that you may find sperm at TC, and you could go ahead and use that for ICSI. Where there is no sperm, then there is the option of going ahead and offering sperm donation. Always remember that in testicular failure, it's not just the absence of sperm, but there is also the role of testosterone, which has got a significant impact on long-term health. So these men will also need testosterone replacement, just like ladies require hormone replacement with ovarian failure. Do I run through all the questions, or do we alternate?
I think let's just pick up a few of them because Prof
Okay.
just finished, so he's reviewing the questions already.
Second question asks, is there a relationship between erectile dysfunction and infertility in men, and whether radiation emission can cause subfertility? Yes, obviously, ED can be due to low testosterone. And if that is in combination with testicular failure, then there might be a subfertility aspect. But just as a direct cause, it could affect coital frequency, and that will also have an impact. So assessment of these men by taking a full history, medical history, psychological history, drug use particularly, would give you the right approach to their treatment. I think the question is asking here to elaborate on the effect of HPV on subfertility. As I said, there is very interesting new research coming through showing that HPV has a detrimental effect on couples going through IUI treatment, and this is HPV in the man, not just HPV in the lady. But overall, when it comes to sexually transmitted infection, you have to look at the global risk. So the presence of one STI could indicate that there are also other behavioral risk factors which increase sexually transmitted infection, use of drugs, and other factors. So that can have a complex relationship with fertility problems. I think I've been asked about what's the respective of male or female factors in recurrent miscarriage. About 50% of recurrent miscarriage will not have an identifiable cause, but we also know that it only affects about 3% of couples who are suffering a miscarriage. The rest may have a cause which is identified, but overall the prognosis tends to be good. We know conditions such as antiphospholipid syndrome are amenable to treatment. For example, use of aspirin and heparin will improve their pregnancies to about 70%. It's always important to exclude uterine anatomical issues. They're more important in second trimester loss compared to first trimester. There's just a very recent publication in Human Reproduction that does show women who have a septate uterus don't necessarily need to have a surgery because their reproductive outcomes are exactly similar to those who didn't have surgery. Of course, there are limitations of that trial. It's always good to exclude thyroid problems. Karyotype may be offered, but it's not useful prognostically. It does help to know the cause. Reason behind this is because even if you didn't do IVF with PGD, there is still about 65% chance that a couple with a balanced translocation, for instance, will conceive and have a live birth. There is possibly very little role when it comes to immune factors in recurrent miscarriage, so it may not be useful to be looking into that. The other question is related to, please clarify the role of male factor in miscarriage. I didn't understand the concept as you mentioned in your presentation. So it's more to do with recurrent miscarriage more than sporadic, but possibly there is also evidence coming up that sperm DNA fragmentation has a direct consequence on reproductive potential. So we see a lot of this in the IVF labs, but we also have evidence to show that couples who suffer from recurrent miscarriage, there could be due to sperm DNA fragmentation. And if you give them antioxidants, that effect may be reversed. I think I'm just running through some of them. The participant might have seen this already, but it's asking what's the ideal weight. I think obviously being healthy with an ideal BMI is the goal. So you wouldn't want to say 5% weight loss. We had a very interesting study that looked at IVF patients who came through looking at the male BMI, whereas we didn't find an adverse effect on live birth rates as we had postulated. It is still advisable that couples and particularly males are advised to maintain a healthy lifestyle and weight. There is obviously clear evidence that spermatogenesis and hormonal profiles are affected by BMI. So men who may have problems, for example, erectile issues or sexual problems with a high BMI will benefit greatly from optimizing their weight, and directly that could also improve their fertility prospects. What's the role of anti-estrogens, e.g. clomiphene citrate in males' fertilities? And are the drugs being researched to improve spermatogenesis in non-obstructive azoospermia? So anti-estrogens may have a role where there is a degree of oligospermia. They certainly wouldn't have a role in azoospermia. And just like in females who have ovulatory problems but with normal gonadotropins, if you used antiestrogens to raise the FSH level, you may improve oligospermia. In azoospermia, especially if it's non-obstructive, then we tend to have very high FSH levels. So giving antiestrogen is actually counterintuitive. And then you may want to consider other options in this sense. I think the other question is regarding a male who has secondary subfertility. What is the approach? And now is azoospermic. Again, just like for primary subfertility, you run through the motions of a comprehensive history. And in this particular situation, you want to make sure that there is no other medical condition that has developed. Always remember that there is the role of the hypothalamic pituitary testicular axis. So a man who presents with azoospermia when they were previously healthy and fertile could have a pituitary problem. You want to exclude prolactinoma, for example. You want to make sure that there is no testicular tumor. It is important to also remember that you may have sperm abnormalities even when there is unilateral testicular tumor. Go back into their lifestyle. Make sure that they are not back into or using anabolic steroids or supplements that could affect spermatogenesis. And obviously, occupational reasons have to be ruled out. And as I mentioned earlier, you need to do a hormone profile, which would give you an idea. It's usually very unlikely, but we have once in a while ran into people who may not volunteer the history of vasectomy. So don't be surprised that somebody might have actually had vasectomy and they are now azoospermic. So remember that.
Thank you very much, Dr. Muteshi.
Thank you.
Right, so for everyone, all your questions will be answered. Dr. Muteshi would try to look at the question, the panelists will review the questions and type in the answers. These answers will be available at thummimng.com all within a week's time. So by next week, Wednesday, they would all be there. We're working with the panelists to make sure that happens. Also, for those who've been asking questions around availability of the slide decks, we will also make that available at thummimng.com within a week's time. I would also like to call on Professor Ashiru to answer some of the questions that were raised while he was presenting. I could read out some of these questions to you and then you can take them on live.
Go ahead.
Okay.
Yes.
So there's this question from Gospel Precious. She says, or he or she says, Prof, how helpful are some of these agents, that is the adjuvants, in female fertility, aside from in IVF situations?
Go on. I will read about 4 or 5, then I can take them together.
Okay, perfect. Then another question from Ifeanyi Chukwu Francis Annie. It says, in combating OAT, that's oligoasthenoteratozoospermia, what are the best treatment regimens to give after confirming the hormonal profile is at a good level?
Yes.
Then another question is,
go on.
The use of erectile dysfunction drugs as an aphrodisiac is on the rise. Is there any correlation between the use of these drugs in a normal male patient without erectile dysfunction for a long time and infertility?
Last one. One more.
One more. And last one. How long? Okay, so this person says that when do you give a patient dexamethasone during the treatment cycle? In addition, how long should the therapy be?
Good.
And then
yes. Yeah. Any other one?
Also, do you give DHEA pre-treatment or during stimulation?
Good. All those are very good questions. One or two more I saw. One that asks which can you give combination, and then which antioxidant is important. Well, when you have female fertility, it is recommended that if you want to have a baby, even before you attempt conception, at least 2 to 3 months before, it is better to take those antioxidants, because the ovarian cycle is actually, even though the menstrual cycle is 28 days, the ovarian cycle is about 60 days, 28 plus. So you want to clear, the same thing with spermatogenesis. So 2 months for female, 3 months for male, before you conceive, you should be taking those antioxidants. So, and even if you are not attempting conception, a number of them helps to reinforce you from removing free radicals that could be carcinogenic. Then in terms of oligospermia, Professor Medrom, a friend of mine in UCSL, has been able to do a number of studies, and what came clear is that for oligotheratospermia, two components. First is omega-3 has been very helpful in improving sperm morphology, because in such things, all you want is a good morphology, and then you can now add those other components that can improve the motility, particularly HCG, which is the human chorionic gonadotropin, can help, and also L-carnitine. Those ones have been regarded as very helpful. But most importantly is omega-3. Some people have, they've published the obituary of L-carnitine and arginine in that aspect. But as Melanie said, L-arginine is useful in terms of the nitric oxide release, which is helpful for erectile function. Then erectile dysfunction drugs. It depends on which ones. The most powerful erectile dysfunction drug is actually L-arginine, 2,000 milligrams. That should help in erectile dysfunction. It's of no, it doesn't have any consequences. Unless you measure the DHEA level in the person and it's low, which is the hydrogen deficiency of the adult male, which also lead to erectile dysfunction. So you may want to give that. Dexamethasone, you should do this before conception, before stimulation, during stimulation, and even after transfer, because the same thing with prednisolone, because some people will use it up to about 10 weeks when you see that the placenta is well formed, because that is when, in fact, the latter part of implantation support is to prevent a rejection at that level. DHEA, ideally, the people recommend using this for about 3 months before in a woman, 25 milligrams TDS before stimulation. Once you get your eggs, you don't need DHEA again. Once you get the eggs, you don't need that. You can drop that. Lastly is which antioxidant should you use, or the combination. There are some products that contain all these antioxidants in some level, but you see, like what Exceltis has done is to have inositol at a high level. So some pharmaceutical company will have a concentration about 2 or 3 or 4 of them and use them. And then you may have to go and look for other things based on the clinical situation of the patient, what you need. I hope that has answered those ones.
Yes,
Any other one?
I can add a few more questions. One is, this is from Mutegi Kevin. He says, is there any guide on antioxidant supplementation among men that have chronic illness? And also, yes, a guide to antioxidant supplementation. Also,
okay.
What is the effect of proposed vitamin supplementation for cases receiving therapeutic vitamin supplementation or certain drug therapies? There's also the question.
I didn't hear that last question. The effects of proposed
Vitamin supplementation.
Okay.
In addition to other drug therapies.
Okay.
Then there's a question from, well, Professor Kabau. And the question is, the supplements constitute a universe of diverse products. How does one choose what to use and when?
Good.
And then,
yes.
If I could just add one more. It says that,
go ahead.
Is there any such thing as too much antioxidant therapy? What is the added advantage with solutions that include lactic acid? And is there a problem with use of such formulations too regularly?
Yes, thank you. The guide to a chronic illness with the kind of vitamins that is needed. The first one is vitamin C, because when you have chronic illness, you need vitamin C to activate your immune system and reinforce your cellular regeneration. You also need zinc. Those are the two components right now that is being recommended to improve your in a biological warfare or in a pandemic that is contagious. You need vitamin C and zinc. Now, that now comes to what the last professor said. Based on the type of pandemic or the type of illness you are dealing with or the patient's condition, you may now increase one vitamin to the other, like CoQ10 if you're dealing with cardiovascular problem, or if you are dealing with heavy metal poison, you will increase selenium to be mobilized the heavy metals out of the body. And then if you want immunity, or if you're dealing with prostate problem or ovarian development or fibroid, you need zinc to help in reducing those things. The next one.
Oh, just a second, Prof. I think you've muted your computer. Just give me a second. Okay.
Yeah, vitamin supplementation, they are okay. And I will say that whatever vitamins you have, you need to look at the manufacturer's specification. We had a problem in Nigeria where one of the pharmaceutical, not even pharmaceutical, they were selling this so-called vitamin supplement. And when you look at the vitamin E that they are dispensing to people, it has about 500,000 times of the recommended daily allowance. Did you get that? Some of them have 30,000 times recommended daily allowance. What you need is 100% of recommended daily allowance, then you get your full dose. If you are now improving that particular vitamins to 5,000 times, 10,000 times, you don't need that. In some special conditions, like in this environment now, you may need like 3,000 milligrams of vitamin C in this type of situation, but not on a regular basis. Okay. I think now in terms of the diverse product of vitamins, usually each vitamins or each supplement have its use, and you have to know what the manufacturer said. I'm happy that, like with Exceltis, they have specified the various use for the components, ingredients of these things, and you can also read them and be sure that you know what you are recommending. For example, vitamin B12 It's very helpful with people with blood problems and hemorrhagic disorders with folic acid in terms of its ability to regenerate the blood and maintain your immunity, especially people who have epistaxis and the rest of it. So is vitamin K for such people. Too much vitamins, I've already explained that. Now the last one was lactic acid. Lactic acid is not a good vitamin to use because it accumulates in the muscles and end up giving problems of muscle ache quickly. So I will stay away from things that have lactic acid. Thank you. Any other one?
Thank you very much, Prof. We're actually quite getting to the end of the sessions. So I'm very happy, I'm very grateful for your contributions. And I know that you will take the time to please review the questions and the open questions in the Q&A section so that we can make answers available to the attendees. And there's also another question for Ayo in this case, or for Melanie. One is,
before you go, Yemi, I think you should thank the over 200 participants that have been patiently watching this and asking questions. I know you do that at the end of the day.
Yes, absolutely.
I need to thank them anyhow.
The only reason why we are here is because they are here. Right? So definitely we're going to thank them. It's just that I had just like 2 more questions for the other panelists before we start winding down.
Good.
Right. So one question was about, okay, Melanie is on now. So the question is about are there any known side effects? And what are the indications for use that you've identified?
Okay, thank you very much, Yemi, and all the people who've asked the questions. So yes, as products, FertiLady and FertiMen are actually very well tolerated products. There may be side effects, but at dosages of 3 to 4 times the normal. And if patients really take 3 to 4 times the normal dosage, they may experience things like abdominal pain, nausea, dizziness, or fatigue. But at normal dosages, the products are actually very well tolerated. Yeah. The indications of the products, I think I can put the slides back up and maybe share my screen again, and you can actually see that.
Okay, and while this is up, can I ask you one more question? Which is that for the FertiLady, is there a recommendation on what time of the cycle the medication should be taken?
Okay, thank you. So no, there's no particular time that is specifically recommended that it should be, that FertiLady should be taken. The dosage is 1 sachet twice daily. That's 4,000 milligrams of myo-inositol every day. And the duration of treatment is normally 3 months. In PCOS patients, you may want to go up to 6 months. However, if you are looking at improving the quality of the oocytes or the embryos, you may want to start at the beginning of the cycle.
Okay, thank you very much for that. One last one for you, Melanie.
Okay.
Is FertiLady associated with high rates of multiple pregnancy?
No, there has not been any report of multiple pregnancies with FertiLady. I think that is mainly associated with clomiphene-based therapies where you get a lot of multiple pregnancies, but not a myo-inositol-based therapy like FertiLady.
Okay, thank you very much. And the last question on the medications themselves is, what's the availability like in Nigeria?
Okay. I know that both products are available in Nigeria, both FertiLady and FertiMen, as they're available in Kenya as well. Ayo, would you like to take that question?
Hello.
Yeah, we can hear you.
Yes, both products are available in Nigeria, FertiLady and FertiMen. So we will have we have the contact of most of the attendees, and we'll all definitely try to reach out in the event that there are people who would want to place a request for the products.
Okay, thank you very much. So we're gradually coming to the end of today's session. We are very grateful for the attendance. Attendance at the peak was about 300 people. And we're very happy that to have hosted this event. We believe that everyone has learned a lot from this. And if there are further questions, please feel free to send them to us. You can reach out to us through the contact page on thummimng.com. We would do our best to make sure you get the answers you want. Where also the panelists would review the questions and provide answers to them as much as possible. These answers, as I said earlier on, will be available within 1 week on thummimng.com. Furthermore, every attendee as well will receive instructions on how to access their certificates within the next 1 week. That is by Wednesday, May 27. You already have access to your certificates. And we expect it to be much earlier than that, but we don't expect it to be any later than that. We say thank you very much once again. Thank you, Dr. Muteshi. Thank you, Professor Ashiru. Thank you, Sogon, and to COGS, and to every other partner on this project. We say a big thank you to you all. Please stay safe. Coronavirus is still very real. Even though we're opening up our economies, we pray that, well, we'll do the right thing and the incidents would go away as quickly as it can. And so if you have any, so I'll just open it for other panelists to just say their bye-byes, and we'll make it a wrap. Thank you.
Thank you. It's been a nice webinar. I'm happy to participate, and I wish you all a safe period at this time. Thank you.
Thank you. Dr. Muteshi?
Thanks very much, everyone, for attending, and it's been a pleasure to interact with you. And I wish you a very nice evening.
Thank you. Melanie?
Thank you very much for participating and for your very interactive participation in session. God bless.
Thank you. And Ayo?
Thank you very much to everyone. I believe it was worth your time, and we are really, extremely grateful to everyone who stayed to the very end of the session. Thank you.
All right, thank you, everyone, and hopefully we'll see you again sometime soon. Bye.
Okay. Bye.